The college lecture will be delivered by Dr. Amal Sithira Tilakaratna, MBBS Colombo, MD Medicine, MRCP UK, FRCP London, FRCP Edinburgh, MRCP UK Rheumatology. Dr. Amal Sithira Tilakaratna is a consultant rheumatology and medical rehabilitation at District General Hospital, Mathale. Dr. Tilakaratna obtained his MBBS with second-class honors at the Faculty of Medicine, Colombo in 2008 and MD Medicine from Postgraduate Institute of Medicine, University of Colombo, 2015. He completed membership of Royal College of Physicians, UK, and the Specialist Certificate in Rheumatology, UK in 2018. He was awarded with fellowships of Royal College of Physicians, Edinburgh in 2021 and London in 2023. Dr. Tilakaratna underwent rheumatology training at Rheumatology and Rehabilitation Hospital, Ragam, and at Russell's Hall Hospital, Dudley Group, NHSFT, United Kingdom. He served as a working group committee member of Asia Pacific League of Association of Rheumatology, Guideline Committee on Telemedicine in Rheumatology. He is also a past member of the APLAR Special Interest Group on Vasculitis and serves as a member of APLAR SIG on inflammatory myositis. He is the current co-editor of the College of Specialists in Rheumatology and Rehabilitation, Sri Lanka. The topic that he has chosen for today is simplifying enthesitis, the hallmark of spondyloarthritis.
Good afternoon, ladies and gentlemen. So the topic I have chosen today is on enthesitis. Why I decided to choose this topic is I have a general impression of, even the rheumatologists have, that we all overlook this aspect of rheumatology where there's enthesitis play important part or rather it's the hallmark of spondyloarthritis. So this is the basic outline of my presentation. I would be talking about give a basic introduction of enthesitis, then would talk about few facts on enthesitis that many think that one of the colleagues, surgical colleagues at Mathale, when this flyer was circulated, asked me if I'm going to talk on Achilles tendinitis and plantar fasciitis for 30 minutes. So I won't disappoint you. I'll talk more or would talk more than on Achilles tendinitis and plantar fasciitis. So basically, we'll describe the immunopathophysiology, which has a clinical implication, and we'll try to sort out or brief you on clinical and radiological assessment, which is required for a clinician. So to begin with, enthesis. Enthesis is the site of attachment of tendons, ligaments, fascia, and capsule to bone. So it's a key target for musculoskeletal inflammation in diseases of the spectrum of psoriatic arthritis. The enthesis is the singular word, and enthesis derives from the Greek word for insertion. When it comes to the term enthesopathy, it embraces all pathological alterations at any sites of enthesis. So the main function, as you all know, is to transduce the mechanical forces to the skeletal system and confer stability. Now, before moving on to describe enthesitis, there are two main histological types of enthesis which are important: the fibrous enthesis and the fibrocartilaginous enthesis. What happens with fibrous enthesis is these are the structures, let's say deltoid, where there is a direct insertion with minimal or limited angles of excursion. So the muscle comes in, the tendon, and which directly gets attached to the bone. Whereas a fibrocartilage enthesis is a structure where prior to the osseous margin insertion, there would be a fibrocartilaginous or cartilaginous structure which would allow more dissipation of energy, mechanical energy, by allowing wider angles of excursion. It's like rather than the tendon getting directly attached, if the fibrocartilaginous is there, it would allow more excursions disperse in the weight only. This description is important for us because in spondyloarthritis groups, it's only the fibrocartilaginous entheses are affected. We don't talk about deltoid enthesitis in spondyloarthritis. So all SPA related enthesitis are fibrocartilaginous. So now this concept, what actually is enthesitis? When I was a medical student or rather a junior doctor, I thought it has just a focal insertional disorder where there is a inflammation at the site of entheses. But with this blind people and elephant analogy, it has been described much more efficiently, because in earlier days, as I thought, it was just the insertional disorder. But later on in 2004, Benjamin and et al. Described it as a sort of with a fibrocartilaginous insertion, it has an organ. But now it is understood that with the recent advances in imaging, particularly the MRI imaging, and also with the understanding of the pathophysiology, not only the enthesis is involved, the adjacent synovial is involved, giving a synergistic effect on inflammation. So moving on, this enthesitis versus synovitis. So this is a schematic diagram which shows that in rheumatoid arthritis, it's mainly the synovium affected, giving rise to synovitis. And in enthesitis, it's extra-articular, but still the enthesis derives blood supply from the synovium. So there can be a secondary synovitis associated with enthesitis, and there are certain enthesial points where it's distant from the joints, like Achilles tendinitis, plantar fasciitis, lateral epicondyles, and cruciate ligaments, longitudinal ligaments in the spine. Now, when it comes to, when I call the spondyloarthritis spectrum of diseases, all these, the hallmark of all these diseases are the presence of enthesitis. So pathophysiology is not the synovitis in these group of diseases, which includes undifferentiated spondyloarthritis, radiographic axial spur, non-radiographic axial spur, reactive arthritis, SAFO syndrome, psoriatic arthritis, juvenile SPS, enteropathic arthritis, as well as peripheral spondyloarthritis. So why should we be aware of enthesitis? So that's because the concept of one size does not fit all. The pathophysiology of synovitis differs from that of enthesitis. So therefore, one single treatment, of, like in the magic potion in asterisk, would not work for all inflammatory arthritis conditions related to inflammatory arthritis. At the same time, I hope that I thought of talking about this concept as well, traditional medicine versus precision medicine. A spondyloarthritis group of medicine or diseases is a entity where precision medicine is now being studied mostly. Where there is a traditional medicine is where all the people would be treated as looking at the clinical phenotyping, and precision medicine is where you would be treating them with genotyping as well as from biomarkers diagnostic points. So in traditional medicine, you would be treating the three groups with same medicine, leading to therapeutic benefits as well as non-therapeutic benefits without a satisfactory response. But in precision medicine, you would give the right pill to the group of green people, blue people, as well as yellow people. So they with the marked therapeutic benefit. So, particularly in spondyloarthritis, in particular in psoriatic arthritis, this concept of precision medicine is coming up with identification of biomarkers. But we are in a transient point. Still, we need to know about clinical clinical phenotyping, because the guidelines which are there are still relies on the clinical phenotyping. This is the psoriatic arthritis management guideline in a nutshell, where they are looking at the clinical phenotyping, peripheral arthritis, axial spondyloarthritis, enthesitis, and etc. So let's move on to the facts about enthesitis. Nail psoriasis is seen in 50% of patients with psoriasis. In the presence of joint involvement, nail changes can reach up to 80%. Have you ever wondered why the nail changes are more common in the presence of psoriatic arthritis? That's because, so these are the typical nail changes: thimble pitting, separation of nail beds, yellow discoloration, and onycholysis. So we would consider, if it is more than 20, as a significant thimble pitting in the presence of psoriasis. So this is because the anatomical relationship the extensor tendons have on the nail matrix. Extensor tendons generally get attached to the nail matrix, giving rise to, in the presence of enthesial inflammation, even the nail there will be nail inflammation causing nail plate changes as well as nail bed changes, giving rise to the chronic manifestations of nail changes in psoriatic arthritis. Then, have you wondered why distal interphalangeal joints are involved in psoriatic arthritis? This is because, again, of the close association of the extensor tendons to the distal interphalangeal joint, where with the synovial enthesial complex, there would be development of distal interphalangeal joint arthritis. We know from our basic anatomy knowledge that the sacroiliac joint is not a purely a synovial joint. Lower 1/3 is synovial, upper 2/3 is fibrous. So how can sacroiliac joint get a pan involvement in spondyloarthritis? So these are the MRIs. You would appreciate that even the upper 2/3 there would be an edematous trace. That's again is because of the ligamental enthesitis attached to or related to the these sacroiliac joints, not related to the synovitis of sacroiliac joint. So looking at the spine in axial spondyloarthritis, again, you would appreciate the changes at the enthesial sites, which is the shiny corners at the end plates, giving rise to the Romanus lesion, which is one of the earliest radiological signs in AxSpA, and it's really related to the inflammation of the annulus of the disc attachment to the end plate. And it can be either can happen in anterior or posterior. So this is a stir sequence image of an MRI where it demonstrates the Romanus lesion, and T1 fat suppression image showing the activity of the active nature of the Romanus lesion. So this is active Romanus lesion. So it's important for us to go ahead with the FLAIR and T1 sequence imaging if we suspect spondyloarthritis, in contrast to routine back pain protocol, where there won't be FLAIR and T1 sequence imaging done to identify the back, mechanical causes of back pain. More on enthesitis, again, anterior uveitis occurs with a very frequency in SPS subtypes, where there would be anterior uveitis is seen in 33% of patients with axial SpA and in 25% in reactive arthritis, lesser frequencies in undifferentiated SPS, psoriatic arthritis, and in inflammatory bowel disease. Again, novel studies have shown with the IL-23 receptor bearing population testing with them that there is a possibility that enthesitis is related to ciliary muscle, anterior uveitis is related to ciliary muscle enthesitis rather than an autoimmune phenomenon. Now talking about spondyloarthritis, all the patients or enthesitis, most of the enthesitis that you come across are of lower limb types, and rarely we come across upper limb enthesitis in spondyloarthritis. Have you ever wondered the reason for that? That's again because in spondyloarthritis, it's not only the immunological process that takes place, the triggering factor is the mechanical stresses, where there would be traumatic, lower limb mechanical stresses would trigger off the immune response, leading to the onset of the spondyloarthritis. When it comes to dactylitis, again, it's a process similar to the Cobner's phenomenon that you see in psoriasis, chronic skin psoriasis, where there would be new psoriasis lesions developing with the superficial traumatization of the skin. So similarly, in dactylitis, what happens is with the repeated trauma, it's a deep Cobner's phenomenon, deeper Cobner's phenomenon type of thing, where there would be stressors on the enthesial or the pulleys as well as the flexor tendons, giving rise to enthesitis. So immunopathology-wise, enthesitis contains a specific immune microenvironment which is activated by the combination of factors that include mechanical stresses, genetic susceptibility, and the microbial triggered immune activation. Exaggerated inflammatory response to mechanical stresses is seen in patients with psoriatic arthritis, as I mentioned, which is similar to the Cobner's phenomenon. So therefore, ultimately, biomechanicals, prostaglandin E2 mediated vasodilation, and innate immune response would lead to the onset of enthesitis and development of enthesitis. So there would be a robust activation of prostaglandin E2, IL-23, IL-17 axis, leading to influx of innate immune cells, leading to a mesenchymal tissue response and new formation. So this is a schematic diagram again. If you can see, appreciate here, there is transcortical vessels in between the NCCs and the bone, which is with the mechanical injuries and stresses, these vessels get dilated, leading to the influx of neutrophils and also transformation of mesenchymal precursors, leading to the bone formation. Same thing here, triggered with the mechanical stressors, there would be a robust prostaglandin response where there would be vasodilatation. Then the T cell precursors, there would be activation of T cell precursors with IL-23 axis, ultimately leading to neutrophil influx with IL-17 and TNF pathways activation. In the meantime, mesenchymal precursors 2 secretes with IL-17 and IL-22 mediators would transform into a mesenchymal cell, which ultimately would secrete head proteins as well as parathyroid-like receptor protein, which leads to ossification of fibrocartilaginous structures, and at the same time, the BMPs would give rise to an osteoblastic response. So ultimately, what happens is, if you look at this substrate, this is by looking at this, people might think that this is a normal X-ray, but this is a plain radiograph where there are earliest signs of spondyloarthritis with squaring of vertebrae and shiny corners indicating Romanos lesions. But if in clinical practice, if we start looking for these spurs or bony structures to diagnose axial spar, what would happen is, by this time already the newborn formation has taken place. So at this point, disease has progressed, and we might not be able to reverse the some of the damages which has taken place. So it's important that if you suspect spondyloarthritis or inflammatory back pain, enthesial inflammation, to go ahead with the right MRI at this point. So comparison of enthesitis versus synovitis. Anatomical location of enthesis is extraarticular, synovitis intraarticular. Tissue composition in enthesitis is fibrocartilaginous. In synovitis, it's the synovial membrane. As I mentioned, there would be a mechanical triggers as well as a danger response, whereas in synovitis, there won't be, it's mainly the autoimmunity which sets in. Type of inflammation in enthesitis is innate, and in synovitis, both acquired and innate immunity sets in. Clinical symptoms, it's mainly pain in enthesitis, whereas synovitis, there would be hard signs of swelling. Preclinical phase in enthesitis would be subclinical enthesitis, and in synovitis, there would be autoantibodies and tenosynovitis. Enthesitis, there would be bone marrow involvement. That is why you would see bone marrow in sacroiliac joints, whereas in synovitis, you would see minimal bone marrow edema. There would be a marked newborn formation, and also a marked prostaglandin E2 dependence, which is of a therapeutic value. Then in enthesitis, there would be IL-23, IL-17 dependence, which is of a therapeutic importance. I will touch on this later, clinical effects on methotrexate, and it's worth noting that enthesitis does not have any dependence on IL-6 and also CD20 cell pathways, since it is not of this acquired immunity is not seen in enthesitis. And TNF dependence is seen in both enthesitis and synovitis, and associated organs-wise, enthesitis, there would be gut enthesial axis involvement and also skin involvement, whereas in synovitis, there would be lung involvement. So clinical assessment, clinical examination of enthesis depends on eliciting tenderness on direct palpation. Unfortunately, this is non-specific and insensitive. What we need to remember is a significant proportion of patients with psoriatic arthritis may have a coexisting central sensitization syndrome, which may bias the clinical outcome measures and may have create diagnostic dilemmas. And clinical examination does not reflect the degree of chronicity and the underlying structural changes. So therefore, the value or the information that you would receive from a general clinical assessment is minimal. So these are the clinical assessment scoring which are available to detect enthesitis. But what we generally do in the clinic is to lead enthesitis index. The rest are mainly research purpose based. So we look at the lateral epicondyles, medial tibial tuberosities, and the Achilles tendons, and would score out of 6. But again, as I mentioned earlier, then this assessment is an inconclusive one. So therefore, imaging may be used to assess soft tissue and osseous changes associated with enthesitis, enabling earlier diagnosis of inflammatory enthesitis, providing an objective assessment. And not only that, it can be a tool to assess the response to therapy. Soft tissue imaging of entheses by ultrasound or MRI may be more sensitive than clinical examination. But it's important to note that there is increasing recognition that biomechanical confounders affects the specificity of imaging of inflammatory enthesitis, like the body mass index and also the biomechanics. Conventional radiographs has a useful place where it could demonstrate the chronic damage with erosions, etc. So what we usually do in the clinic setup or the rheumatology setup is the musculoskeletal ultrasonography, where it could visualize non-axial entheses in great detail, as the majority of them are superficial. Vascular rate can be also assessed, but assessment of deeper tissue are not possible with MSK ultrasonography, where MRI would be beneficial to assess the bone edema as well as bony changes, in addition to the soft tissue changes. So these are, it's not just keeping the probe on a tendon and diagnosing. It's what we look at is a cumulative scoring system. I won't go into details on this because it's involved advanced rheumatology and musculoskeletal radiology. So finally, what are the clinical implications on this? So going back to the pathophysiology, I mentioned that there would be a robust prostaglandin E2 receptor activation, also sort of prostaglandin E2 response activation. So NSH plays an important role not only for symptomatic control, it's therapeutic control in enthesitis, because what will happen is with NSH, the COX-2 inhibition or COX-1 inhibition, conversion of arachidonic acid to precursors would lead to decreased production of prostaglandin E2, thereby leading to a therapeutic response. Then, the second line, when NSAIDs and injections fail, would try methotrexate. The recommendations are from methotrexate, but in clinical practice, rather, we use both methotrexate and sulfasalazine. The reason behind this exclusion of CS DMARDs or conventional synthetic DMARDs from the guidelines, there is no robust evidence with clinical trial evidence. But in clinical practice, actually, we generally, with the when we see enthesitis, first we would be trying on methotrexate, then would add on sulfasalazine, and then would switch to biologic DMARDs. So as I mentioned, TNF alphas, because of the response here, IL-12 and 23 inhibitors, that is ucicinumab, and IL-17 inhibitors, that is secukinumab, and also JAK2 inhibitors, which is from OPAL trial, and also phosphodiesterase inhibitors, that is aprilimast, causes all these except for methotrexate has shown a significant benefit in clinical trials. And if one fails, what we do is switch the biologics or switch your JAK2 inhibitor, or you may try prostaglandin or aprilimast, which is a phosphodiesterase inhibitor, but unfortunately, this is not available in Sri Lanka. Same principles goes into the management of axial spondyloarthritis. That is why, because of this prostaglandin E2 robust activation, you would be trying on 2 NSAIDs prior to initiation of biologic DMARDs in axial spondyloarthritis. So finally, I would look at this typical case history, where a 45-year-old female diagnosed with psoriatic arthritis comes with the reports on widespread pains, reduced, unrefreshing sleep for last 6 months. Pain persistent throughout the day, with the same intensity. And she is on methotrexate 20 milligram weekly. There are no swollen joints, and she is tender over the bilateral epicondyles as well as the BIP joints. Her inflammatory markers are normal, full blood count and PSH, electrolytes, everything normal. Her DAPSA, that is the scoring system which we use for psoriatic arthritis to measure the disease activity, shows a moderate disease activity. PASI is where you look at the skin scoring system. It's in remission. Patient was initially commenced on duloxetine with a partial response. So these are the typical cases that we come across. What are the causes for white plain syndrome in her? Obviously, you need to think about fibromyalgia. That's why with multiple tender points, unrefreshing sleep, we have added duloxetine. But despite optimal doses of duloxetine, there had been a partial response. Probably there's because there's underlying polyanthesitis in her. How can we differentiate between each other? Unfortunately, clinical differentiator would not help much. Therefore, she needs further imaging. Any other investigation? That is the radiologic imaging. And how would you manage this patient? That is, if once the therapeutic escalation of pain modulators has failed, you might try escalation of a disease-modifying treatment in her. So, first for clinicians, immunopathology in enthesitis differs from sinusitis. Multiple enthesial site inflammation. Think about SPS spectrum. Clinical and biochemical assessment alone would not help in most cases. Remember, inflammatory markers may be normal in most instances. Radiological assessment assists in diagnosis and monitoring, and we may need to review the diagnosis of non-responding central pain syndromes, where we call managed as fibromyalgia for many years, might be a polyanthesitis associated with spondyloarthritis spectrum. Request MRI lumbar spine in the right context. That is, you need to, if you think about enthesitis, request it as per SPS spondyloarthritis protocol, not as per the routine back pain protocol. And it's important to look for the feet. Examine the feet if somebody complains of upper limb enthesitis. Don't forget dactylitis. So I would like to thank President and the Council of Sri Lankan College of Physicians for inviting me to talk on the deliver the lecture of college lecture today. And thank you very much.
Thank you all for this excellent lecture and making this important for the disease. Thank you very much.
And it is my duty to thank the two YPL resource persons and the college lecture, and thank the judges, Dr. Harsha Sachchandra and Dr. Dhanapal Disanayake, and our organizers of the event from the council, Dr. Indika Boteju and Dr. Dinushka Jayavir Bandara, and the sponsors for the event, CIPLA and Sidus. And thank you very much, the attendees, for your undivided attention, and have a good day.